We received an ambulance call about 15, 20 minutes before class, a possible cardiac arrest. So if that ever happens, if I'm gone, so it's usually because we had a high acuity call, and we'll just figure out when that happens. But so patient assessment tonight. This is actually encompasses 3 chapters in your book, which is chapter 11, 12, and 13. And I'll send the like workbook sections if you want to do them. I'll try to do that tonight or tomorrow latest. So how it's broke up is vital signs, which we'll kind of start with first, then scene assessment, then the actual patient assessment. So the slides, these are a lot for the EMT, so there are some things that don't really pertain to the EMR. I'm not going to use the slides much tonight, or I'll fly through them a lot. Patient assessment is a lot hands-on. Vital signs are vital signs. We do that the same for everybody. Scene assessment's a scene assessment. But patient assessment, how many of you worked like EMTs here? Were you still taught medical trauma assessments? Yeah. Okay.
2 separately?
Yeah.
Yeah.
And I think the book and the text might still differentiate the two. Really the big difference is the medical assessment. So a medical complaint, trouble breathing, chest pain, stroke, seizure, all that stuff. It's a lot more questioning and not physical exam, whereas the trauma assessment is much more physical exam focused, because we're trying to identify injury. I make the argument that every assessment should have questioning as far as medical history and physical assessment. So what we're going to teach you here is just an assessment. You'll kind of learn everything, and when you have a patient, you can omit things and add things. So, for example, if you get called to Winnipeg, I'll just use that for an obvious broken leg, we don't have to go through the whole chest pain question, right? So we can omit that portion of the assessment. We can do kind of a head to toe, look for things that are immediately threatening, and then focus in on that actual leg injury, just as an example. So we'll kind of get started. Vital signs, we do these on every patient. They've got a handful listed here. But when we say baseline vitals, I want you to think of 4 different vital signs that we take. Respiratory rate, heart rate, blood pressure, and if you have the tool, pulse oximetry. Those are our 4 kind of baseline vital signs. Ideally, those vital signs are obtained within 10 minutes of first medical contact. So if you ever hear me use the term FMC, that means first medical contact. So when you walk in, I come in and say, "Hi, paramedic Jason, may I help you?"
No.
I get consent.
No.
All right, sign it. But, once we obtain consent, these are or we get to the point of vital signs, these are things we do. Now, you'll see other things in here, specifically skin and pupils. Pupils, I would make an argument that we may look at the pupils, but this is more of a secondary finding. So regardless of what the pupils are doing, they're not going to die from unequal pupils per se. They might die from the cause of it, but there's other things that we have to assess first. In skin is one of those assessments. It is the largest organ. So it's important that we assess it, but we're kind of doing that simultaneously with these other assessments, or other vital signs. I'm not sure. There's some additional findings that we had checked, or what I would call secondary vitals. Okay, and a lot of these we don't have to repeat. We kind of do it once, but just to kind of touch on. So we talked about pupils. You can make an argument it's a vital sign. Capnography. Capnography is, and we have referenced this a few times, we're going to talk a lot more about it when we get into respiratory illness, probably in medical 1 section, but Capnography, capnometry, both same thing. It's a measurement of the carbon dioxide we exhale.
You said capnometry?
Yes, so there's two terms. Capnography provides a graph, a visual graph that we can see what our monitor. Like an EKG for your lungs, if you will. Capnometry is the number. So I can look at a graph, and that graph usually corresponds to the number. But either way, I need a capnography equipment to get that. And a lot of EMRs, you don't carry them in your kits. For those that were in the ambulance, our cardiac monitor, that has our capnometry / capnography device built into it. So I think you can get like a portable device put in your bag, and you put like a nasal cannula on somebody. And I think you can get them, they start for like $2,500, which is why you don't see a lot of EMRs carrying it, right? It's something we need to know about, but it's not priority. Blood glucose assessment, that is very well within the EMR scope, and this may be, it is reasonable that an EMR may carry a glucometer in their kit. Glucometers are fairly inexpensive. I think the actual machine is like $10. And test strips, they're a little bit pricier, but about $15 for generic test strips. And we'll get into that and why we would check blood glucose later. Pain assessments considered a vital sign, and there's a lot of different ways to assess pain. We'll touch on them. And body temperature. Now, we can feel a person with our hand. It's a very subjective, and I can tell you a warm feels normal, and they feel kind of cool with my hand. The thermometers that we carry, even on the ambulance, horribly inaccurate. I have yet to find a thermometer that is somewhat accurate, and if I really need an accurate thermometer, we're not doing it in the mouth. That makes sense. So we do rectal thermometer. We do have a rectal probe that we attach, and if we feel it's a clinical thing linked to their body temperature, then we may have to do rectal. So rectal temperatures are common in pediatrics. So if we have a baby having a seizure, we're doing a rectal temp. About the only time I do rectal temps on the adult population is when I'm concerned about hypothermia, especially if they're unconscious, because we adjust some of our paramedic stuff based on their core temp. For the EMR, you guys don't have to, we're not going to be doing rectal temps in calls. Makes most of you happy, some people might be sad. So yeah, hypothermia is kind of the big time, or if I have a severe cold or heat illness, I kind of prioritize that temp. Or I guess if patient requests it. Respiratory rate, this is, I'm going to go off on a little bit of rant with this. So we'll focus on the four main vital signs. Respiratory rate, how many times we take a breath over a minute. The adult should breathe between, and textbooks will tell you 12 to 20 breaths a minute. And, obviously they're in pain, they're nervous, you might breathe a little bit faster, but I don't like those numbers, and this is based off my experience. Most respiratory rates are actually closer to, that we see on the ambulance at 12 to maybe 16, maybe 18. We start to see respiratory rates getting at 20, and especially when they hit 22, that can be clinically concerning. So, just as a general example, that when your body is going into what can be called shock, that your body is, there's different stages of shock. We've got a whole unit, we'll talk about this, but the first stage of shock is what we call compensated shock. So your body is compensating for whatever's causing the shock, whether you're bleeding, you got a severe infection, you're having a severe allergic reaction, your body's compensating initially. And that compensation will actually hide what's actually going on. So you might think, well, if they're bleeding, the blood pressure is low. Well, not initially. The blood pressure actually initially goes up, and then it drops. So it depends on what point we come in to take that blood pressure, assess vital signs. They might be on the spectrum as they change. when your body's going into shock, your body's kind of working in overdrive, so you're creating a lot more waste products, specifically carbon dioxide. So people start breathing a little faster as a way to get rid of those acids. And has anyone ever heard of sepsis? So sepsis, systemic infection, affects all your organs, usually originates from a pathogen, a bacteria or a virus. But in those early stages of sepsis, their vital signs are really good, except they have these subtly higher respiratory rates, like 24, 26, and it doesn't look like they're breathing fast until you actually count it. So a lot of different ways you can count respiratory rates. You can sit and count how many times they breathe over 1 minute. Most commonly is we watch it for 30 seconds and we multiply by 2. That's kind of what I do now. If I do that and the number seems odd, maybe I'll listen for a minute. Now breathing, if I'm staring at you,
Creepy.
yep, trying to watch you breathe, you're holding your breath right now.
I might have, you put me on the spot, so I
If you
panicked.
know I'm watching you breathe, you're gonna start changing your, like, what do I do? Do I breathe normal? Do I hold my breath? It's just a human reaction. So when we assess vital signs, a lot of times I do it without them knowing, so can I feel your pulse? I just
Sure.
wanna check your pulse and your wrist, okay? So I'm gonna count this for 30 seconds. So what I'm actually doing is I'm watching her breathe, but I'm distracting her by taking her pulse. Now, I will take her pulse, but I might do 30 seconds breathing and then 30 seconds heartbeat. But, so when you're doing a respiratory rate, it's kind of important to distract. And by me just slightly putting my hand on the back, I can kind of count that movement. So that's what I found to work best for that. Anybody breathing faster than 20 breaths a minute, we call, the term for that is tachypnea. So tachy, anytime we put tachy in front means fast. So tachypnea, or if I say she's presenting tachypnic, tachypnea is fast breathing. Tachypnic means they're presenting it, I guess, pertaining to, yeah, it's not important. But tachypnea means breathing fast, where bradypnea, Brady, means slow breathing. Hypoventilation is another term. Actually, I should kind of differentiate that too. Hyperventilation does not necessarily mean breathing fast. So when I talk hyperventilation, hypoventilation, it's really more pertaining to volume. So hyperventilation is usually a faster rate associated with faster volume. But I can breathe, I can be tachypnic like this. Does it look like I'm breathing fast? I'm breathing about 70 a minute. Real shallow. I'm not moving my chest so much, but that's what a really septic patient, they can be breathing 40, 60 times a minute. And when you walk in, they don't look to me in respiratory arrest until I get down there. I have to correct. Usually at that point, they're unresponsive, but respiratory rates are huge, and we don't need to get so much into the pathophysiology of what causes fast breathing, what causes slow breathing yet. We're just talking about, we find it and report it.
You said tachypnea is breathing faster than 12 breaths per minute?
20.
20.
And there's different texts. Usually, I don't call it tachypnea until usually more than 24 breaths per minute. It's relatively subjective. You know, so I wouldn't get too tied up on that. But, you know, if you're at a call and someone's breathing 30 times a minute, and you're giving a report to the ambulance, you could say they're tachypnic, tachycardic, you know, tachycardia, bradycardia, or fast and slow heart rates. Yeah, and I know I forgot something, but we'll come back. So whenever you see these charts, I'm gonna tell you right now, try not to, don't waste brain energy trying to memorize, well, if it's a 4-year-old, you should be breathing at, that's what we carry charts for. Okay, so every EMR has a flip book or some type of chart system that you know, we can, okay, this is their normal range. I don't put a lot of weight into it because normal ranges, I mean, you can be very, very sick and be very well within the normal ranges of your vital signs. So again, it's relative to the situation, but it's just kind of painting a picture there that the younger they are, the faster they breathe normally. We had alluded a little bit during the airway unit about different respiratory patterns. So respiration, for the most part, there should be a very smooth pattern. Inhalation, exhalation, inhalation, exhalation. But when it becomes really irregular, some speeding up, slowing down, or just really deep and rapid, with these abnormal patterns, I can tell you that you probably won't see any of these specific patterns, and at the EMR level, it's not so much important for you to dive in and be able to recognize the different ones, but these people aren't awake and talking. So Shane Stokes and Biatz, I get the two screwed up quite a bit. It's very irregular patterns with periods of apnea. So apnea means without breath. So if we say the patient's pulseless and apneic, it means the heart isn't beating and they're not breathing. But, so like Shane Stokes would be a real irregular pattern. And where we see this is a lot with head injuries. Agonal is probably another common one. Agonal is dying breaths. So they're taking real kind of almost snoring, these non-purposeful gasping, these agonal. Q-small is usually a normal respiratory rate, maybe on a higher level, but very deep and rapid. Or not rapid, but very deep. And we see Q-small respirations, just to jump ahead, with high blood sugar patients. So people who are in like a diabetic coma. So I don't want to dive into pathophys because we're going to talk about that in medical emergencies. So just again, patterns that we should have a normal pattern. Anytime we see irregular patterns, it's concerning. Respiration should be quiet. We touched on this stuff too. So remember snoring, gurgling, stridor, that's all that upper airway stuff, right? And then your wheezing, rales, rhonchi, that indicates more lower lung that we identified. It says audible with the stethoscope, but I would make an argument that well, not an argument, I can tell you that I've had audible wheezing, audible rales, audible what can I kind of simplify this? That when we use the word audible, so audible stridor, audible crackles, audible wheezing, it means I can hear it without a stethoscope. So I'm standing next to the patient, I can hear them wheezing. That would report the patient had audible wheezing. You may not, if you have to put a stethoscope on someone to listen to their lungs, and then you hear it, it's still wheezing, it's just not audible unless we put a stethoscope on. Does that make sense? Your rales and your rhonchi are just going to sound like wet lungs, like they're breathing and there's water. It's kind of bubbling or making a sound. It's not important for you to differentiate between rales and rhonchi. That you can just say, yeah, I listen, and your right lung sounds wet. Just kind of report what you say. Or both lungs sound wet. Pulses, at the EMR level, for the most part, we check pulses in well, I guess I'd say probably four areas. So carotid, right here in the neck, your carotid artery runs right along the windpipe. So when we're checking pulses, we're checking in centrally. And I say that because a lot of times I see people checking out here. Usually what I do is when I'm looking for a carotid is I put my fingers right on their windpipe and I just slide my fingers off to the side. Femoral pulses, I think I gave you guys the assignment, if you have the ability or find someone to let you try, but looking for femoral pulses kind of right here in the groin. And then radial pulses is generally on the thumb side. If you follow the thumb down, you find this kind of little softer indentation right above the tendons, if that's where we look for radial pulse. Brachial pulses, up here, and you can find it on an adult, but that's primarily where we look for pulses on infants. So next time you're around a baby, practice finding brachial pulses. When someone says, "Here, want to hold my baby?" Yeah. I'm going to check out this stuff. Look for the brachial pulse, feel the fontanelle. You know, that's your chance to do a pediatric assessment. The popliteal, the tibial, the dorsalis pedis, these we're not routinely checking, and we'll show you on the feet when we get to like trauma, when we're checking pulses in the feet. Sometimes we can't feel them, it doesn't mean they're not there. But if I have a broken leg, I'm gonna go down here on top of the foot and feel if I have a dorsalis pedis pulse. And that's just telling you that blood flow is moving. There's other things we can assess too, but that's what, there's another pulse behind the knee. I don't think I've ever checked for that one. Once you find a pulse on a patient, like in the feet, mark it with an X or an M, so next time you gotta check it, you know, right where you go, you're not digging around for it. So, like respiratory, pulse rates are the same. Technically, anything over 100 beats a minute is considered tachycardia. Anything less than 60 is bradycardia. Does not mean it's necessarily a bad or a good thing. We're just documenting what we find. Remember, heart rates and respiratory rates, they can change over the course of a few minutes that we're there. So, when I talk about repeating vital signs, that we check vital signs, and depending on what's going on with the patient, 5 minutes, 10 minutes later, we check them again. And over the course of our time with the patient, for an hour, between the pressed dial and the output, we can probably comfortably check vital signs 6 to 8 times. And what we're doing is we're looking to see, are they staying the same, or are things starting to change, or we start to see trends of either getting faster, slower, vice versa. For heart rates, kind of my red flag triggers are when we start to get heart rates less than 50 or more than 130. Those are kind of red flags that we need to do probably some intervention. Slow heart rates, I will tell you, my experience is very seldom do we have to treat slow heart rates. That people, even elderly, can tolerate slow heart rates pretty well. Don't need a lot of intervention real quick. Fast heart rates, I probably treat tachycardias 4 times every one time I treat a slow heart rate. If you're assessing, obviously, someone who's active, an athlete, you know, up here, people are hitting windman every day, skiing, all doing physical activity, that they condition their hearts. It's normal for their heart rate might normally be in the upper 40s to 50s at rest. And when we're checking vital signs, you just ask the person, what's your heart rate usually? You'd be surprised how many people say, oh, my heart rate's usually in the 60s. So if you check it and it's 58, well, it's probably not that far off from baseline. Or if you check their pulse and it's 52 and they say, I'm usually running at about 80 beats a minute. Well, that's kind of a concern. You know, you shouldn't be 50 if you're usually 80. Again, just a chart. Don't worry about memorizing this. The younger you are, the faster your heart beats, the faster you breathe. Adult 60 to 100. For me, heart rates start to get to 90 or more. I start to get a little concerned that most resting heart rate shouldn't be 90 or more. Now, you got to kind of look at what's going on with the patient. I'll use for an example. You guys get called to me out in the parking lot. I snap my finger. femur kind of looks like the letter Z, shouldn't look like that. Am I gonna be breathing fast? What? Is my pulse rate gonna be up? What? Does it mean I have some cardiac rhythm disturbance because my heart rate's 140? No. It means my femur's broken and it hurts really, really bad. So that's when I have tachycardic and might be breathing faster, right? So you gotta, we can't just take that number and immediately look at it. So you kinda gotta look at the overall picture of what's going on. You know, the whole pulse quality, so when I'm getting a rate, or I'll even back up that a lot of times when I'm first coming in, so because you sat up front, I'm gonna use you a lot.
Okay.
Okay, so I'm gonna probably be touching you a lot tonight without your permission, okay?
All right.
That's all I need. So when I come in and let's say she's called because she can't breathe, I'm gonna come in and say, hey, I'm Jason with the ambulance, can I take care of you?
Sure.
Okay, I'm gonna feel your pulse quickly, tell me what's going on. You can't breathe.
I can't breathe.
Okay, so right here, I'm not really taking a pulse rate. What I'm doing at that point is I wanna know, is it there? And my general quality, what's it feel like? So, cart in front of the horse, it's kind of our theme tonight, but this vital sign stuff is, we're usually doing this kind of after we've done an initial, what's gonna kill her in the next minute? And then what's gonna kill her in the next 5 minutes, then I'll do my vitals question. But, so by grabbing that pulse, all I'm doing is checking quality. Number one, is it there? So if I can feel a pulse in someone's wrist, that tells me there's enough, her heart's generating enough pressure to get blood up to her brain, okay? If I don't feel a pulse in her wrist, I kind of stop there and say, this is part of my primary ABCs, if you will, and I might have to do some things to fix it. We have a pulse.
Pretty sure, because I can find.
But when I'm looking at quality, number, obviously, can I feel it? It's telling me it's strong, or is it real, like I'm getting you know, it's kind of, I'll feel a couple beats and I don't feel a couple beats. I'll feel a couple beats and I don't. You know, that's weak. Pulsus paradoxus, they put this on here, I don't know if I mean. Pulsus paradoxus is, if I take a breath in, and if you find your pulse, some of you may feel your pulse weaken a little bit as you breathe, that you feel the strength of the pulse, kind of get a little stronger, and then just a little weaker. And it's super subtle. That's pulsus paradoxus. There's some things that make it more pronounced, but when I take a breath in, we talked about this, my lungs expand, compressing my vena cava a little bit, which decreases the amount of blood coming into my heart. So it takes that pressure, drops it down just subtly, but it changes as I breathe. Does that make sense? And we'll manifest that later in lab class. And regular, irregular. So a pulse rate should be, for the most part, like a metronome. Pretty regular, but if I'm feeling a pulse and it's doing kind of no rhyme or rhythm to it. That's what we call irregular heartbeats. Could be a lot of different things, could be perfectly normal for the patient, but just can we feel the pulse? Is it regular, irregular, and kind of overall quality. Skin. Overall skin color, I'm looking at a patient, and this I'm kind of doing simultaneously with pulse check, looking at breathing, as we're looking at the skin. That, do we want to see, and it's kind of hard to, I'm just kind of looking over here, everyone has good normal skin color. Some people are more pale than others. You know, I'm red-headed Irish, so I'm either white, severely sunburned, or white. There's no tanning that ever happens to me. But when you see someone who's pale and the face will literally look white. Skin assessment is subjective, so you're just saying what you see. And it's not uncommon. We come into a house, we have a male on his bed, and he looks pale. The wife's there. I'll just, after I get kind of caught up, I'll look at the wife saying, is that how his skin is normally? Do you notice any difference? Because she looks at him, or a family member looks at him every day, she may say, yeah, he's always pale. Okay? You know, that the wife's reporting that's a normal skin color. The other thing that we might notice is the presence of diaphoresis. So diaphoresis is basically sweating, and it's sweating when they shouldn't be sweating. So you respond to a call, summertime, it's 95, someone is out on the lawn for an hour, now is having chest pain, you would expect them to be sweating. Right? We come into a house tonight, and someone's sitting in their recliner, drenched in sweat. That's diaphoresis. Diaphoresis, or sweating, I guess what I would say, sweating when they probably shouldn't be sweating. That is, for me, one of the biggest clinical red flags, that something is seriously wrong with this person. Anytime you, or you're with someone and you see them all of a sudden break out in sweat when they shouldn't be, they need an ambulance evaluation. Like, you don't have to ask any other questions, just call 911. Sweating is, there are a lot of different things that cause it. None of them are usually good. So get an ambulance coming as quick as possible. But the presence diaphoresis, cap refill, this is something that's usually taught with kids, but I use it all the time on adults. If everybody takes their nail bed, let's have painted nails. Well, you can do it anywhere you have skin. If I push on my hand like this, and I take it away, notice that it's kind of white, and then the blood fills back in. On your nail beds, that's cap refill, so if I push on my nail bed, make it white, let go, it should pinken up. White, and then I count. 1, 1. Delayed cap refill, it takes more than 2 seconds. So people who have poor circulation, or it takes longer for the blood to move, if I push down on that, and I let go and it stays white, slowly, takes like 3 seconds for it to get pink again, that means they have, something is delaying circulation getting to those nails. Could be a lot of things, okay? But delayed cap refill is a really good skin assessment. And I've done it on people's foreheads. You know, if someone's really sick, they just push on the forehead. And I can do this while I'm initially doing my first 3-second exam. And it's a good way to check cap refill.
I just thought it was fun. Just sitting there on the bed. So, like, what's the best area to test? Just anywhere?
Anyway, yeah, usually nail beds work real good. In fact, capillary refill is kind of our go-to for pediatrics.
Would it vary? Like, let's say you did the fingernail, but would it be slower on the,
If I'm, like, if they're outside, if someone's been outside, there's like a snowmobile right now, right? Cap refill and stuff like that probably is not gonna be a really good assessment, especially if they have taken their gloves off, their hands get cold. Because cold, vasoconstricts, it's gonna slow down the blood flow, right? So it's not a true accurate of what their circulation is, then I would wanna check centrally. You know, I'm gonna take a shirt down and push here. You know, does that get, you know, it's a couple second assessment. We talked about cyanosis. Yellow coloring, has anyone ever seen people jaundice? Okay, literally yellowish color, and it gets really concerning when you start to see the whites of the eyes become the yellow of the eyes. That usually when someone's skin gets jaundice, the sclera of their eyeballs will also get jaundice. Jaundice, number one indicator is that something's wrong with the liver. Okay, and it could be, you know, primary liver. I mean, it could be anything that runs into the liver, pancreas, anything that stops that liver from clearing stuff out. That when you start to accumulate things that the liver should be processing, that can turn your skin jaundice or yellow. We don't have a fix for it. These people usually either have a very chronic condition or they need to be in an intensive care unit. This is something that doesn't get fixed overnight. Pupils a little bit, at one point, kind of during our secondary exam, if we check pupils, well, I'm just gonna put eyes and pupils. So not a primary assessment thing, this is something we're doing a little bit later, if we have time to do it. But when I look at the eyes, first thing we'll check is pupils and we use a light. So if I get it dark, pupils will dilate to let more light in, right? And if I shine a light in their eye, we'll see their pupils quickly shrink down to a smaller size. So when I first have a patient, whether they're laying on the back in their sofa, as I look at their pupils, are they equal? Are they both the same size? And at some point, I'll take a pen light and we just move the pen light past this eye, or pick an eye, doesn't matter right or left, I just hit one eye with it and then move it off, and I wanna know, does that pupil react to light? And when I shine a light at or near it, I should see the pupil constrict, and when I take it away, it goes back to where it was. And then I do the same thing with the other eye, does it constrict with light, go back to where it was. And then I do it one more time, but I watch the other eye. So if I shine a pupil in this eye, the other one should constrict with it as well. So I'm looking, are they equal, reacting to light? Unequal pupils, I don't know if that had a, I'm gonna go with that picture. So unequal pupils, and this is, I mean, you can see them this pronounced. We can see here where one is relatively constricted. This one's much more dilated as compared to that, okay? So, first off, when I see unequal pupils, I ask the patient, do you have unequal pupils? And I'm actually been, and it's called anoscoria. I've been surprised how many times the patient has said, yeah, I was born with that. That's just how they are every day, all day. Okay, good to know. Our car accident. We had a really bad car accident right out here last year. We get him in and check his pupils are unequal. And he, in between screaming, actually I was born with that. We were like that all the time. I went back and screaming. I'm like, well, that's good to know because we almost intubated you. So this could mean, where we get concerned with unequal pupils is if you have like trauma in the brain and there's swelling, and now we got some pressure compressing one of your optic nerves, it can cause that side to, actually it's opposite, because your optic nerves actually crisscross. So if this eye is dilated, that means I'm bleeding over on this side, and vice versa. Super constricted pupils, when we see that, number one cause is it's bright outside, so we're at the summer and I'm looking at their eyes, they're super constricted down with the sun's beating in it. Otherwise, we see constricted pupils with opiate toxicity a lot of times. Not definitive, because what we noticed in Wisconsin Rapids, they do a little bit of opiates, and they do a little bit of methamphetamine. So methamphetamine dilates the pupils, opiates constrict, so they kind of cancel each other out. They got normal pupils, but they're not breathing. So if they're not breathing, they're unconscious when they're not giving market. Otherwise, dilated pupils, you know, we can start getting into toxicology, different substances people take. So your sympathomimetics, we call methamphetamine, amphetamine, those dilate your pupils, right? So it's just part of the finding. The other thing I'll look for is their gaze. Can they follow a finger? Do both eyes look? And when we talk about trauma injuries, if you get an injury to one eye or an impaled object, we cover them both of them. So if I only covered the injured eye, let's say someone gets a muskie hook in the eye, and we cover that eye up, and we got him in the ambulance, and I'm over here, and I ask him a question, what's he gonna do? He's gonna look, right? And when one eye moves, they both move. So we want to isolate both eyes. If we have a fixed gaze, occasionally you will find patients where their eyes are fixed in one position. They're usually, I shouldn't say usually, they'll be unresponsive at that point, but really bad head bleeds or strokes, they'll actually tend to look towards where the injury is. So if I've got a massive bleed here, we'll get there, they're unconscious, they'll probably have irregular respiratory patterns that change scopes. They're looking this way, and this pupil is dilated and this one is constricted. That's pretty classic. There's something going on. So again, nothing we do to correct it. And I think your textbooks will show you a picture of a disconjugate gaze. Oh, if that was my patient, I'd have to step out of the ambulance for a second. But yeah, no, that's unequal pupils, and they probably just like that stuff. All right. So we'll talk about blood pressure quick, and I'll take a quick break before we dive into the actual patient assessment. But all right, so blood pressure. When we do, blood pressures are, again, subjective and relative, meaning your books, you're gonna read about, heart attacks, or sometimes the blood pressure. Don't ever try to think, well, if the blood pressure's high, it's one of these things, or if it's low, it's one of these things. I'll use an example. So when someone goes, has anyone ever heard of heart failure? So depending on the type of heart failure, but you can develop what's called pulmonary edema, where fluid begins to build up in your lungs, okay? So, and this can happen very quickly. So we'll kind of start, let's say at time zero, someone's left ventricle fails. It's not pumping effectively. Within a few minutes, the patient's going to develop symptoms of that. And because that left heart isn't pumping effectively, but the right heart keeps pushing blood to the lungs, the left heart can't get it pushed out, so we start to get pressure backing up in our lungs, and that pressure causes water to get pushed out of the capillaries into our air sac. So they develop this pulmonary edema. They go into respiratory arrest, or not arrest, but respiratory distress. And they're struggling to breathe because they can't exchange gas. They call 911. Their body recognizes that and is trying to fix it, so it's actually going to start dumping adrenaline, right? And what we're going to see is their blood pressures will start to go up, 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 up. Their heart rate's going to start to go up, 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 up. Their respiratory rate's going to start going up, 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 up. So when we get there, if we get there at 10 minutes, we're going to notice them mildly tachycardic, mildly tachypnic, blood pressure's high. If we get there 20 minutes, you might take their blood pressure and it's sky high, 240 over 140. Heart rate's sky high, 140s, 150s. And then if we just don't do anything and watch them, probably in about 30, 40 minutes, we're going to start to see it coming down to normal. And then at about 45 minutes, it's going to start getting below normal. Now their blood pressure's dropping, their heart rate's dropping. And then in a few minutes after that, they go to cardiorespiratory arrest. So at what point do we walk in and check the vital signs? Right? That's kind of what I'm trying to get at. So we may see it normal, we may see it elevated, we may see them normal again, we may see them lower. All of which are heart failure. It just depends at what point we're checking them. Okay, does that make sense? So don't try to match blood pressures up to specific.
So pulmonary edema, is that specifically a heart thing?
Mostly. I can go down a rabbit hole, non-cardiogenic pulmonary edema. You hike a mountain, you can go into pulmonary edema. You take opiate overdoses. People, in fact, most of our fentanyl overdoses have pulmonary edema, wet lungs. And it's because they desaturate over some time that causes this shift of fluids in their lungs. But for the most part, when we see pulmonary edema, 99 times out of 100, it's left heart failure. Okay? So basically, I just said all that so you don't start getting in the habit of trying to equal high, low, normal blood pressures with specific disease factors, because it depends at what point in the spectrum of their disease we step into assessment. But when we're doing a blood pressure, we're trying to obtain two numbers, a systolic and a diastolic. So when you hear like 120/80, it's a number, line, and another, almost like a division. The higher number is the systolic. And what that number is reflecting is what is the pressure in your arteries when your heart is contracted. So obviously when your heart contracts, there's more pressure. But then when your heart relaxes, that pressure drops. That bottom number is a reflection of your diastolic, or the relaxation of the heart. So we're trying to get two numbers, trying. Sometimes we only get the top number. So the primary methods of taking a blood pressure is auscultating it, which is a blood pressure cuff with a stethoscope, where we are listening, pumping up a blood pressure cuff, taking that blood pressure. Another method is called palpating. That's where we put a blood pressure cuff on them, and we're just feeling for the pulse to come back. But we can't identify the diastolic number when we're palpating. And then the third one, the most unreliable, is the non-invasive cuff that we use on the machine. So if you ever go to a clinic, the doctor, they put a blood pressure cuff on you and they push a machine, push a button, and it, I don't trust it. I'm sure they'll say they're calibrating and stuff, but non-invasive, NIBP, non-invasive blood pressure cuffs, they estimate the diastolic. And why the diastolic is important to me, does anyone remember when the coronary arteries fill with blood? During diastole, when the heart is relaxed. That's when so if you don't have a good diastolic number, you're not getting good coronary flow. So no, I don't want to estimate. I want to know what that means. Now, how many of you have taken blood pressures before? Okay, so, and if you haven't, that's okay. That's what a lot of people get nervous about taking blood pressures, and we're going to get you through this. This chart, obviously endorsed by the American Heart Association, because, once your blood pressure, once we say you're hypertensive, what do they put on you? Medicine, right? Is there money to be made? I'm not, I apologize, but I'm just saying. 120/80 is kind of considered where we hope people to be. As you age, your top number tends to go up. In fact, how I was taught is the systolic is generally 100 plus your age. So for example, I'm 49 years old. I would expect my systolic blood pressure to be 149 over something. I want that lower number to be less than 90, because if you think about it, I don't want a lot of pressure in my arteries when my heart's relaxed, right? So when you're looking at people that have high blood pressure, again, it's subjective based on their primary care provider. At what point do they need to medicate and treat them? I can tell you from my experience, just family and friends, they are really quick to put people on antihypertensive or blood pressure medicine. Very quick to do it. There's definitely some modifiable things that a person can do before they get put on blood pressure medication. Diet, salt intake is huge. So just changing your diet a little bit. A lot of times people go in a couple weeks, and if they truly modify the diet, blood pressure is better. So, I'm going to use this chart here quick. You're going to hear me, and I know people say this probably isn't needed in EMR, but I think it's important you get there's a really big push in EMS that we're starting to teach this even to the EMT, EMR level. And we look for, has anyone ever heard of mean arterial pressure. It's the MAP. We know MAP needs to be at or better than 65. When we have a MAP or a mean arterial pressure less than 65, it's telling us generally we don't have adequate cardiac output. We're not generating enough pressure to get to all our vital organs. So how do we figure out the MAP? It is 2 times the diastolic blood pressure plus the systolic blood pressure. No, you didn't think you'd be doing math. And divide that number by 3. That equals, your math. Does anyone know what 65 times 3 is?
Well, that's 195.
195. So, I'm one that I like to eliminate unnecessary math. So when I'm estimating math, I just eliminate the divide by 3. 2 times the diastolic plus the systolic, I want that at or better than 195. Does that make sense? Now, the reason they don't want to teach at the EMR level, because what if you determine the MAP to be 170 or less than what it's supposed to be? What are you going to do? Well, unfortunately, the EMR scope, they don't have the ability to do IV fluids or IV medication with the blood pressure. But I think it's important that, you know, if I showed up on the ambulance and you said, hey, I got a blood pressure of this with a map of this, that's huge, huge for me. Otherwise, I can try to do the math in my head, but let's do this. So let's take 120 over 80 as the blood pressure. So what's 2 times 80? 160 plus 120. So 2 times the diastolic, 2 times 80, plus my systolic, 120. Remember, I was 120 over 80. What was that, 280? Which is at or better than 195, right? So my mean arterial pressure or my blood pressure is good. And the reason I use MAP more than blood pressure is because if I took everyone's blood pressure in this room, what do you think the difference is that I'm going to see? Huge. Yeah, I mean, maybe your blood pressure may be 94 over 60 years. That's your normal blood pressure. I'm just using it as an example. Ian, you might run 138 over 74. And that could be kind of where your normal is. That's, you know, a 40-point difference in systolic rate. But you both are, everyone in here right now is clinically stable, but our blood pressures may be completely different. But what I do know is everybody in this room right now has a MAP of 65. So that's why I use MAP, because it doesn't matter what your actual number blood pressure is. I just need to know, are you generating enough pressure to perfuse it? And at the EMR level, there's not much you can do to change what you find. You just check it and report it. Does that make sense? So to take the blood pressure, there's a couple different ways, but generally we put the blood pressure cuff on. And as soon as I'm done with this, I'll give you guys a break. On all blood pressure cuffs, you're going to see an artery marker, or there's going to be a little arrow. And we want to try to line that up with that brachial artery. The artery actually comes down kind of the middle of your arm, and then right about here, we call this space here the antecubital space. And that artery comes and it kind of crosses almost over the center. So when we are going to take a blood pressure, ideally, first thing you do is you get down kind of on the medial aspect of the arm, kind of at the bend of the arm, and you start feeling around in there for a pulse. Some people are easier to find than others. We want to try to line that artery arrow up with that artery, so it's usually, if we take the medial aspect and the anterior aspect, and we go at about a 45-degree angle, that's kind of where I line that marker up. Now, if you're off a little bit, it's not the end of the world, okay? In fact, if I had this arrow way off on the outside, it's still gonna work. You know, I might be off a couple points in accuracy, but it's still gonna work. So I just kind of get in the habit of, I try to line that up with not the middle, but a little bit towards their inside of the arm. That's where I line that up. What this shows is that you find where that pulse is, and we tighten up, or blood pressure cuff has a way to let air out, and we have to, some got like ours, some of ours have a trigger, some have a little thing you gotta screw shut. Either way, you wanna make sure it's closed, because if you're sitting there and you're pumping it, and nothing's happening, it's probably because you have the valve open. So close the valve, so we can actually get air into it. And start pumping it up, and you'll see the needle on the gauge start to go up. That's telling you we're starting to generate pressure. But this method is, I'm feeling that pulse as I pump it up until I don't feel the pulse anymore. That means now I've shut that arterial supply off. I'm above the systolic. So I'll generally go like 20 more, then put the stethoscope on and start letting it down. That's one way. I don't do it this way very much, because if I'm feeling a pulse, I pump the cuff up, lose the pulse. Okay, now I gotta get my stethoscope. They're all set up. Meanwhile, this person's sitting here with the cuff pumped up. What I like to do is I put the stethoscope kind of right over the top of that artery, and I start pumping that cuff up. And you're gonna hear this, right? And I keep pumping it until I don't hear it anymore. And I get up just a little bit, maybe 20 after I stop hearing a sound. Then I start slowly letting it out. So, and I'm watching that gauge. It's not going fast. And you start seeing that needle kind of bounce. Where that needle lines up with that number, where you first heard that heart sound, that's your systolic. That's the top number. And we just keep letting it down. And when we don't hear it, that's our bottom number. So if we let it down really fast, we'll just hear we want to go a little bit slower so we can give the heart time to kind of bounce. Okay? Does that make sense? I'm just telling you about it. We're all going to practice and play with it. Not tonight, but that's kind of one way of taking the blood pressure. The other way, and so we're looking at that gauge, and has anybody never looked at a blood pressure cuff before? You go grab them, I'm just going to pass them around. So this is the gauge we're watching, and it's usually by 10 or 20. And when you're looking at it, we're not super exact on it. I mean, you might be off by a couple, by 2 or 4, but that's for the practices of what we do. That's fine. And blood pressure, please know, blood pressure changes throughout the day. It can change from minute to minute on people. I think as an example, I pick someone up there. I take a blood pressure, it's 132 over 75, or 74, because when we're doing it this way, it's even numbers. 10 minutes later, I check it, it's 132 over 70. Check it again. You know, it might fluctuate 6 or 8, either way, on the top and bottom number, and that's perfectly normal. Palpation, this is when I can't hear a pulse. And as people's blood pressures drop, I might not, if it's really low, it might be hard to hear it. Or you're like me, you're hard of hearing, or I'm really in a hurry and I just need to know at this point what that top number is, because I'm worried your blood pressure is low, we can palpate it. And palpating a blood pressure, I'm just getting the estimated systolic number. So put the blood pressure cuff on, just like I did. I'm gonna find a radial pulse, and I start pumping the blood pressure cuff up until I lose the pulse, and I start letting it down. And when the, I gotta look at this first. Okay, so there's different sizes for different people, but, so with this one, for example, this is a blood pressure cuff. I don't know if this is ever been used. Actually it has the, I can't really pronounce this, big monitor. That's what this is, and there's many different variations of this. This has a gauge, so when I first started, I make sure it's calibrated. So when you pass this around, look, you're gonna see a little rectangle down there, and that needle at rest should be somewhere in that needle. If I take this out and I look and the needle's outside that rectangle, that means the calibration's off for us to throw the garbage or no. But this is within that rectangle, and it does kind of graduate by 2 intervals. Adult size. With this one, this is my left arm. Should line that up with the artery right arm, so if I'm putting it on my left, kind of line it up. Here's my left arm arrow, that's a little where I put it. Now, if I'm, off a little bit, it's not the end of the road. So don't get too tied up on, perfect lining up like that arrow. I'll take your blood pressure.
Sure, do you want me to use that?
I can, actually, palpation is something I can do real quick. So she's stuck in a car, not really responding to me. I can just put this on real quick. Okay, so I found her radial pulse. I lost her pulse, so I'll go for about 20 more. And I just start slowly letting it down. Okay, I felt the pulse come back to about 122 on here. So you're 122 palpitating. That's good. So you're not unconscious from your blood pressure. Now we gotta look at what else. Maybe Narcan is next. I don't know. Kind of lastly, once in a while we'll do what's called orthostatics. And orthostatics are, what we want to see is if positional changes affect your blood pressure. So if I'm on day 3 of chronic gonorrhea, and I'm just using it as an example, not actually. If I'm on day 3, I've been running to the toilet every 15, 20 minutes. I have lost a lot of my fluids, okay? And it doesn't have to be blood, but just body fluid. Your body has to have a good balance rate. So I'm low volume. And I'm laying down because when I sit up, I feel dizzy and weak. When I sit up, I feel dizzy and weak because my blood pressure, when I sit up, it's harder for gravity to put my blood up. So orthostatics are, I check a blood pressure when they're laying flat, and then I change their position more to upright, either sitting up, and maybe even standing up, and I do their blood pressure and pulse rate again. And if I see a change of more than, I think it's 10 or 20, it's what we call positive orthostatics. It's a clinical indicator that they're volume depleted. Now again, EMR, not much you can do, and if they're feeling dizzy, or you sit them up and they say, whoa, I feel dizzy, lay them back down. We don't need to do orthostatics at that. I do a poor man orthostatic, meaning I grab their pulse and I change their position, stand them up, and if I feel their pulse rate go up, that's a positive orthostatic. They need fluids. It's kind of what that tells me. And I think that is it. We'll come back. I'm not going to do death by PowerPoint tonight, so we're going to We'll come back, we'll kind of finish up with the vital signs, and we're gonna get in and do actual, talk about patient assessments, yeah.
And is it a good idea to make sure their feet are uncrossed? What do you think?
Make sure their feet are what?
Uncrossed. Well,
Oh, yeah, I mean, that can falsely make their blood pressure seem up more, but I rarely do orthostatics. I grab a pulse, sit them up, if I see their heart rate go up, they're getting a liter of fluid to start, so.
if you had to do a blood pressure, and you couldn't get their legs uncrossed, like if they were in a car, and you couldn't, what would you estimate that their blood pressure would actually be? Because it's gonna be higher.
I don't think, I think it might 5, maybe 10 millimeters of mercury. Not much, that if it's a critical trauma patient, and I'm worried about that top number, cross, uncross, it's not gonna be enough for me to. But orthostatics, you know, it might change, but when you stand them up, you know, if I do laying down, sitting up, and then standing up, and, you know, for me, it's when we change our positions, you know, it's like, how do you feel? Are you okay sitting there? And then I take the blood. And usually we're doing orthostatics when someone's like, I'm fine, I don't need to go to the hospital. Okay, can we just do this one test? And usually when they stand up, they're like, oh, I feel like absolute right now. And we rarely even get that blood pressure because we're laying them back down. Okay, mine's made up, we're going to the hospital. All right. So, let's, what time is it? Okay, let's kind of take the final break and then we'll, get into patient's assessment.
Been looking at him and where are you going? Yeah. It's good. Makes me cool.
Friday, Saturday, one of those. Ready? Yes.
Katie said you were, I don't think the report's on. Were you on that meeting call?
Yeah.
You were the first in the state of Wisconsin.
Wow. That was awesome. That was pretty cool.
How was it?
Good. Yeah, real good.
So a lot of pain, not so much.
Casey sitting there like, kind of freaking out. And
Broken leg.
then he was like, displaced. It kind of looked like it would be like a dislocation. There's no way.
Trying to get
a lot going on.
So, clinically,
Cool of it.
Other
Something very uncomfortable, but a lot of it was like, slow.
like I asked you, for you drink?
not sitting there playing on his phone and got his daughter.
That was really cool, because like when we were moving him,
Suicide.
like he didn't have that, he would have been screaming, I think. But if, that like, since he had it, he was just like,
We're doing a new therapy. We're one of paramedic services that are trying to send. So, ketamine is a paramedic medication. We can use it for.
She's not there. It was so long, but we gotta make sure she's not there. She could get there any minute, or just, it's right now. But also, that's just like,
Sometimes.
my last one, see what she's at, out of
expense count,
Yeah.
get large, but you.
I know that's how I roll in my career, just to team and stuff, so, I needed to get a plain board.
Yeah, he's a dramatic guy.
I guess they give them a different type.